how we are going to treat the urinary tract obstruction. Usually, 2 to 3 other questions usually will come from this session. First, we will see about the pathophysiology of the urinary tract obstruction. The urinary tract obstruction, if you are not relieving any obstruction, either due to a calculus or either due to a disease, it usually lead to a permanent renal damage. So the degree of injury usually depends upon the severity of the obstruction. Actually, for this session, I will speak about the theory and I will tell what are the important points for the examination MCQ points. I will tell the important slides. You can make a note of it. Apart from that, I will generally briefly tell about what is the pathophysiology so that it can be useful for in your clinical practice also. And I will tell this important areas where MCQs will be asked. So the degree of injury usually depends upon the severity of obstruction. Either it is either a unilateral kidney is obstructed or it is a bilateral kidney obstruction, and whether it is an acute obstruction or chronic obstruction. All these factors only depend how the kidney is, the degree of injury occurs. So coming to the causes of urinary tract obstruction, these are all not much more important. Causes, as you know, congenital causes like renal cyst, polycystic kidney disease, any stricture of the ureter, stones of the ureter, any malignancy, renal malignancy or ureter malignancy, or any infectious etiology, any pathology that is going to obstruct the kidney, either obstructing at the level of kidney or at the level of PUJO or at the level of ureter or at the level of BUG, that is near the bladder. In all these cases, the pathophysiology is the same, but the causes may be different. These causes are not much more important for MCQ purpose. Just I am put it in the slide. Some other causes are usually we commonly encountered in our clinical practice is stone disease, either a stone causing a unilateral kidney obstruction or the bilateral ureter obstruction. Other causes are trauma, aneurysm, not much more important. Some lower genital urinary causes like at the bladder level, that is the posterior urethral wall, phimosis, even malignancy in the bladder carcinoma, prostatic carcinoma, or carcinoma of the penis. All these causes obstruction of the urinary tract. These are the other causes like retroperitoneal fibrosis, trauma, urinoma, pregnancy. Even pregnancy also causes the urinary tract obstruction. So before going to pathophysiology, just to briefly know about what is physiology of the renal function, so that we can able to understand better about the pathophysiology in the urinary tract obstruction. So what is glomerular filtration rate? Glomerular filtration rate is nothing but it is calculated by a formula by a net filtration pressure and Kf. Kf is a coefficient and it is a constant factor. So what is net filtration pressure? So as everybody knows, as a nephron has both glomerulus and capillaries. So the net filtration pressure is depend upon hydrostatic pressure and colloidal osmotic pressure present in the glomerular capillaries. So this net filtration pressure, either a favorable filtration, that is, it may either increase the GFR or either it may decrease the GFR. So the GFR is depend upon hydrostatic pressure and colloidal osmotic pressure of both glomerular capillaries and in the Bowman's capsule. So as I previously told, the GFR is maintained by all these four forces. Main two forces are, one is hydrostatic pressure and another is oncotic pressure. Where this hydrostatic pressure, one is in the glomerulus and another one is in the Bowman's capsule. And also oncotic pressure in two areas. One is at the glomerular, that is at the capillary level, and another is at the Bowman's, that is outside the glomerular level. So you can see in this figure. So this is the glomerulus and this is the Bowman's. As I already told, GFR is depend upon two pressures. One is hydrostatic pressure and another is osmotic pressure, that is oncotic pressure. So two areas this pressure will be there. One is in the glomerular level and another one will be in the Bowman's. So there will be a glomerular hydrostatic pressure and there will be also a glomerular osmotic pressure, and there will be a Bowman's capsule hydrostatic pressure, and also there will be a Bowman's oncotic pressure. Why in this figure there is no Bowman's oncotic pressure mentioned means Bowman's oncotic pressure, that is the pressure in oncotic pressure in the Bowman's capsule, is very negligible. That is, it's almost equal to zero. So only it is neglected in calculating the GFR. So these three factors only determine the GFR, that is glomerular hydrostatic pressure, another one is glomerular osmotic pressure, and another is Bowman's capsule hydrostatic pressure. This is the normal pressure values. Normally hydrostatic pressure in the glomerulus will be 60 mm of mercury and their oncotic pressure will be 32 mm of mercury, and Bowman's capsule hydrostatic pressure is 18 mm of mercury. It is calculated by this formula. as I already told, GFR is K, that is the coefficient constant. One is difference between the hydrostatic pressure of the glomerulus and Bowman's capsule minus difference in the oncotic pressure of the glomerular capillaries and Bowman's capsule. As I already told, since this Bowman's capsule oncotic pressure is very, very negligible, we are omitting. So the net normally the net filtration pressure of a normal kidney is 10 millimeter of mercury. So the next question comes, what is glomerular hydrostatic pressure and what is glomerular oncotic pressure? Glomerular hydrostatic pressure is nothing but we already know glomerulus is nothing but it's afferent. It consists of afferent arterioles and afferent arterioles. It is the main renal blood flow to the kidney. So this hydrostatic pressure is determined by the renal blood flow. So whatever the how much amount the blood is coming, it depends. It favors the hydrostatic pressure. So when blood flow is decreased, that is when afferent arteriole is affected or some other physiology or any other blood flow is decreased, then the hydrostatic pressure is also going to be decreased. What is glomerular oncotic pressure? It is nothing. It is nothing but it is the proteins present in the renal blood flow. So it produces the oncotic pressure. What is Bowman's hydrostatic pressure? Bowman's we know that glomerular hydrostatic pressure is mainly by the renal blood flow. That is depending upon the renal blood flow. But Bowman's hydrostatic pressure is the pressure that is maintained by the urine. That is what is the amount of the urine going from this glomerulus to the proximal convoluted, then distal convoluted tubule to the collecting the pressure in the entire tubular area gives this Bowman's hydrostatic pressure. So now you understand. So GFR is depends upon two pressure. One is hydrostatic pressure and another is osmotic. Where this both pressures, one in glomerulus level and another is in Bowman's level. Since oncotic pressure of the Bowman's capsule is very, very negligible, almost equal to 0 millimeter of mercury, we are omitting it. So the net filtration pressure is calculated by the difference in these pressures. So glomerular hydrostatic pressure minus hydrostatic pressure of the Bowman's capsule minus hydrostatic pressure of the oncotic pressure, and the net pressure is almost equal to 10 millimeter of mercury. This is the normal. So so now comes what are I told two pressures. One is hydrostatic and another is osmotic pressure. So which force favor the GFR? That is favoring is increase the GFR. So as I already told, whenever renal blood flow is increased, that is renal blood flow is increased via afferent arteriole, then as already told, renal blood flow only determines the glomerular hydrostatic pressure. So when renal blood flow increase, glomerular hydrostatic pressure is also going to be increased. Hence glomerular hydrostatic pressure is increased, GFR also increased. So the when hydrostatic pressure in the glomerular is increased, GFR will be increased. That is why they are giving forces favoring the filtration. That is forces favoring the GFR is glomerular hydrostatic pressure. And another pressure which is favoring the filtration is Bowman's osmotic pressure. But I already told that the osmotic pressure in the Bowman's capsule is very, very negligible, 0. So we are not considering. Then coming to the forces opposing the filtration, that is decreasing the GFR. So that is opposite to that. That is hydrostatic pressure in the Bowman's capsule. That is tubular pressure. That is tubular pressure in the ureter and distal to the nephrons. That forces, that is the pressure in the Bowman's capsule will oppose the filtration. So whenever pressure is more in the Bowman's capsule, then the GFR will be reduced. So this is the brief. The two factors that favoring the GFR is, one is glomerular hydrostatic pressure, which is depend upon the renal blood flow. But the factors opposing the GFR is hydrostatic pressure in the Bowman's capsule. So coming to the physiology, what will happen when afferent arteriole is constricted? We know blood flow is coming via afferent arteriole. Whenever there is a constriction of afferent arteriole, what will happen? Renal blood flow will be decreased. As I already told, renal blood flow only favors the hydrostatic pressure of the glomerulus. When renal blood flow decrease, hydrostatic pressure of the glomerulus also decrease. Hence, as a result, total GFR will be also decreased. So coming to the opposite, when it is the constriction of the efferent arteriole, that is distal to the after the blood passed and goes out, that is in the efferent arteriole, what will happen? There will be increased pressure in the glomerular hydrostatic pressure of the glomerulus, and this will increase the GFR. So remember, the hydrostatic pressure of the glomerulus depends upon renal blood flow, whereas Bowman's capsule hydrostatic pressure is depend upon the tubular hydrostatic pressure, that is in the ureteral pressure. So coming to this, till now what we talk about basic physiology. Just when we know briefly about that, so that we can able to better understand the pathophysiology of the rest of the obstruction. So only I told about that physiology. Then comes about the proper urinary tract obstruction. There are two types of urinary tract obstruction. One is unilateral urinary tract obstruction, and another is bilateral urinary tract obstruction. Unilateral means one side of the kidney is going to be obstructed. Either it may be obstructed at the level of kidney, either obstructed at the level of PUJO, or at the level of ureter, or at the level of PUJO. And bilateral is bilaterally both kidneys are going to be obstructed. Commonly we encounter in our clinical practice one side obstruction. So if just you take an example. For example, if one side of the kidney stone comes and obstructs the one a portion of the ureter, what pathophysiology is going to occur? So initially if a stone is obstructing the kidney, three phases in the unilateral obstruction occurs. So in all these obstruction, you must remember two things: what is going to happen in the renal blood flow, and what is going to be happen in the GFR, and what is the pressure going to be happen in the ureter. So these three factors only is important in determining the outcomes of the obstruction. So when in the case of unilateral obstruction, there are three phases. There will be triphasic pattern of changes will occur in the kidney. Triphasic means three different phases of the changes in the renal blood flow and the GFR occurring during the course of obstruction. So these three phases called as triphasic pattern. This triphasic pattern is only seen in case of unilateral obstruction only. This will not be seen in case of bilateral urinary tract obstruction. So what is phase one? Phase one is patient presenting within 1 to 2 hours. What is the changes occur? Phase two is when patient is delayed presenting after 3 to 4 hours. Phase two presentation will be there. Late phase is when patient is having unilateral obstruction, but he is not bothering about. Then he will go for phase three. So coming to then we will see what is phase one. So phase one is, for example, if a stone is obstructed, this phase one is occurring in first 1 to 2 hours. What will happen? What will happen once there is an obstruction? There will be pressure in the ureter will be going to be increased. Then as a result of this, renal blood flow will be also decreased. So initially there will be a pressure in the ureter will be because stone in the somewhere in the ureter or kidney, so pressure will be increased. As a result, renal blood flow will also going to be decreased. But what will happen is there will be a compensatory mechanism will be occurred. That is since the renal blood flow is decreased, our body try to increase the renal blood flow. How? Vasodilators are going to be released. Predominant vasodilators are PGE2 and nitric oxide. This will act in the pre-glomerular level, that is apparent arteriolar vasodilation occur. As a result, the kidney try to compensate the stone and it will start to increase the renal blood flow and the GFR will be maintained. So at the initial presentation, at 1 to 2 hour of presentation, the patient will be normal only because his own body compensatory mechanism will be able to compensate the obstruction so that his GFR will be maintained and renal blood flow will be also maintained. This is due to vasodilators release and this will act on the pre-glomerular apparent arterial vasodilation. So now the exam question is, in unilateral urinary tract obstruction, what pattern you will see? There will be a triphasic pattern will be seen, and what is the important mechanism for how they are compensating the obstruction is, this is due to the vasodilators released which will act on the pre-glomerular apparent arterial vasodilation. This is the question. So in unilateral obstruction, there will be a pre-glomerular, this vasodilators will be released as a compensatory mechanism and they will act at the pre-glomerular apparent arterial level and this will cause vasodilation. Then comes to phase two. What is phase two? Phase two means, as already told, it is 3 to 4 hours of the obstruction. When patient is not going to treatment and he is leaving the treatments, what will happen? This obstruction the obstruction will be persistently present, and also that hydrostatic pressure will be also going to be increased. Here the hydrostatic pressure, what they are telling is, it is in the ureter pressure. Either a stone may be obstructed in the mid ureter or distal ureter. That ureter pressure will be going to increase because urine can't able to pass distal to the obstruction. So, but this compensatory mechanism, what I told in phase 4, will act for only for short times. That is for 1 to 2 hours only. After 1 to 2 hours only it will act. After that, if the patient is not going for the treatment, what will happen? This compensatory mechanism also going to decrease. So what will happen as a compensatory mechanism is decreased? Again, the renal blood flow starts to decrease. If renal blood flow decrease, what happen? Hydrostatic pressure in the glomerulus will be decreased. If hydrostatic is decreased, GFR also decrease. Hence, in phase 1, renal blood flow and GFR will be maintained But in phase 2, the renal blood flow and GFR also starts to decrease. What will happen in phase 3? Phase 3 is more than 6 hours. Patient is not going for any treatment. There will be all compensatory mechanism will be lost. So as a result, that vasodilator effect will be totally weaned up. At this stage, there will be a pre-glomerular apparent vasoconstriction. As I already told in phase 1, there will be an apparent vasodilatation due to the release of the vasodilators. But in phase 3, all mechanism will be compensatory mechanism will be lost. As a result, there will be an apparent vasoconstriction. As a result of this apparent vasoconstriction, all renal blood flow, GFR, and all this tubular hydrostatic pressure. The tubular hydrostatic pressure, what they are going to here they are implying is ureteric hydrostatic pressure. This will also going to be decreased. So decrease in the GFR in late phase is due to. So at the end of the unilateral obstruction, at the end of the day, that is the if patient is not going for any treatment even after 24 hours, what will happen to his kidney will be that GFR will be decreased. The reason for this decrease in GFR is pre-glomerular apparent vasoconstriction and decrease in the hydrostatic pressure of the glomerular capillaries, and there will be a global lack of perfusion. The kidney perfusion also going to be decreased, and there will be shift in blood flow from outer cortex to the inner medulla region. So this is the diagram. As I already told, remember unilateral ureteric obstruction has 3 phases. That is triphasic pattern. This pattern is only specific for unilateral. It is not specific for bilateral. Remember, this is the exam question. What is the 3 phases? One is acute phase, another is mid phase, and another is late phase. Acute phases, as I already told, it will happen first to 1 to 2 hours, and the mid phase is 2 to 5 hours, and late phase is after 24 hours, even after there is no treatment is going. So in acute phase, there, as I already told, renal blood flow and GFR will be maintained. How it is maintained? That is due to the vasodilators released, and these vasodilators, where it will act? This will act in the afferent arteriolar level, and it will cause vasodilation. As a result, renal blood flow and GFR will be maintained. But in late phase, this renal blood flow and GFR is going to be decreased. Why it is decreased means all compensatory mechanism will be lost, and there will be an, instead of afferent arteriolar dilatation, there will be an afferent arteriolar constriction will be there. Hence, renal blood flow is decreased and GFR is also decreased. So the question is, usually they ask in the unilateral ureteric obstruction, what is the pattern you are getting? The triphasic pattern is the classical pattern in unilateral obstruction, and also in unilateral obstruction, initially the GFR is maintained. How it is maintained? It is due to the vasodilators. What are the important vasodilators? One is nitric oxide, and another is PGE2. Where it will act? It will act on the afferent arteriolar level, which will cause vasodilation. But in late phase, there will be an apparent arteriolar vasoconstriction. Then coming to the bilateral ureteric obstruction or obstruction in the solitary kidney. Either both kidneys are obstruction, or a patient having only one kidney. In that kidney, there is an obstruction. So this there will be no classical triphasic pattern when compared to unilateral. Here we will not see any triphasic pattern. From the start of the obstruction itself, it is a bilateral. So it is an emergency condition. In urology, this bilateral ureteric obstruction is an emergency condition. You should go and treat the patient either in the form of either minimally procedure, or you should do a routine endo procedure to relieve the obstruction. Otherwise, the kidney will go for end renal stage. So in bilateral ureteric obstruction, that classical triphasic pattern will not be seen. There will be from the start itself, there will be an vasoconstriction will be there. Hence, renal blood flow and GFR will be decreased from the obstruction. From the start of obstruction itself, there will be a decrease. There will be no vasodilatation at all. Only vasoconstriction only will be seen. So, in all these changes, so in changes in this bilateral mainly mediated by arterial natriuretic peptide. So remember, this is the exam question. So changes in unilateral ureteric obstruction is mediated by vasodilators, but changes in bilateral ureteric obstruction is mediated by ANP, that is arterial natriuretic peptide. Why this peptide is increased means, this is because in bilateral obstruction, what will happen? Patient will present with anuria, no urine output at all. So his body volume will be, intravascular volume will be increased, and there will be an accumulation of more urea and other solutes will be increased. So as a result, as a compensatory mechanism, ANP will be released, and this ANP is responsible for their vasoconstriction, increase tubular pressure, and also it inhibit the renin release and promote the natriuresis. All these lead to decrease in the renal blood flow and GFR. So in bilateral ureteric obstruction, the points you should remember is there will be no classical pattern. Here that bilateral ureteric obstruction, from the beginning itself, renal blood flow and GFR will be decreased, and this is mediated by the factor by ANP, where in unilateral ureteric obstruction it is mediated by vasodilators. So this is the bilateral ureteric obstruction. This phase is not classical in case of bilateral ureteric obstruction. So this is the question. Now I explained fully, but as a brief, this you should remember. In unilateral ureteric obstruction, there will be a triphasic pattern, which is mediated by vasodilators, and there will be a prolonged initially there will be a vasodilatation and followed by only vasoconstriction. But in case of bilateral urinary obstruction, from the phase one, from the obstruction beginning itself, there will be a vasoconstriction. As a result, renal blood flow GFR will be decreased, and this is mediated by ANP. Here it is mediated by vasodilators, nitric oxide and PGE. So what are the other changes occurring in bilateral urinary tract obstruction is another one is there will be since there is a bilateral obstruction, these other factors also occur. These other changes is only peculiar for bilateral urinary obstruction. One is there will be a down regulation of sodium transporter. As a result, natriuresis, that is there will be sodium will be lost in the urine. Another one is down regulation of aquaporin. As we everybody know, aquaporin is responsible for water reabsorption from the collecting duct. Hence, there is a down regulation. There will be lead to polyuria, and also urine concentrating ability will be lost, and this lead to increase in the urinary pH. So partial. What is partial? Partial means there will be the stone is not completely obstructing. There will be some partial obstruction, but it also behaves same like unilateral urinary tract obstruction, and there will be ultimately there will be decrease in the renal blood flow and GFR. So what we till now what we are seeing in what it's going to happen in the glomerular level, and now we are going to see what are the pathophysiological changes occurring in the tubular level. So as already told, urinary concentrating ability will be lost because aquaporin channel will be down regulated. Particular channel is aquaporin 2. As a result of this down regulation, there will be polyuria after the obstruction is slipped, which is more common in bilateral urinary obstruction. You remember all this concentrating ability, that the sodium loss and acidification ability will be lost, but both in unilateral and bilateral, but it is more specific for bilateral urinary tract obstruction. Why in unilateral this is not specific is opposite kidney will be normal, so they can able to manage this function. But in case of bilateral, since both kidneys are affected, this urinary concentrating ability, sodium loss and acidification ability will also be lost. So as I already told, sodium transporters also will be down regulated. Hence, there will be salt wasting. There will be natriuresis, which is greater in though we can see in both, but it is more greater. There's more amount of sodium loss will be in bilateral urinary tract obstruction. Then coming to acidification, as I already told, acidification capacity will be also lost, and also patient urinary pH will be elevated. So other cation, what are the other losses means K plus excretion is also increased in case of bilateral urinary tract obstruction, and magnesium excretion is both increased after the relief of both urinary tract obstruction and bilateral urinary tract obstruction. So all these changes, as I already told, all these changes, that is apart from the in tubular level, these four changes will occur. One is loss of urinary concentrating ability, another one is sodium loss, another one is loss of acidification. All these changes occur both in unilateral and bilateral, but it is predominant in bilateral urinary tract obstruction. But it is not seen typically after the relief of unilateral urinary tract obstruction, because contralateral normal kidney will maintain the fluid and electrolytic balance. So all these tubular loss, that is tubular function loss, will be more typical after the relief of bilateral urinary tract obstruction compared to unilateral urinary tract obstruction. Coming to the some pathology. So what pathological feature we will expect in case of urinary tract obstruction is, if you are not going to relieve with the obstruction in 21 to 28 days, cortex will be thickened. As already know, everybody knows, when obstruction is not relieved, there will be hydroelectronephrosis, since cortex and medulla will be diffusely thinned out and parenchyma will be lost. At 6 weeks, the entire kidney will lose almost its function and will appear as a cystic appearance. So in microscopic level, this is also an example scenario previously asked. Most common histopathological changes occur in the obstructive urinary injury is tubulointerstitial fibrosis. The tubular level, there will be the all there will be fibrosis occurring at the tubular level. This is the most common histopathological changes in the obstruction of the renal injury. Obstructive renal injury. Late changes is entire kidney will be go for sclerosis, which is called as glomerulosclerosis. So in this is the pathophysiology in brief. First, there will be an obstruction. What there will be a renal injury occur. In renal, after due to renal injury, angiotensin II will be released. This angiotensin, importantly, what will they will recruit inflammatory cells into the interstitium, and these inflammatory cells, that is monocytes and lymphocytes, what will do means they release all transforming growth factors. They will be released. This will lead to fibrosis of the tubular cells. What I already told, which is the tubulointerstitial fibrosis, is the most important microscopic changes occur in obstructive level is due to the release of angiotensin II, and due to the release of all these growth factors that lead to the interstitial fibrosis, which is called as epithelial mesenchymal transition. That is, all tubular epithelial cell will be converted into a mesenchymal cell, that is myofibroblast fibrosis. And this is also an important question. Again, previously they are asked why most common cells susceptible to apoptosis. Actually, we know there are two type of cells. One is in tubular epithelial cell, another one is glomerular epithelial cell. But however, as I already told, glomerular cells are usually resistant to apoptosis, but only tubular epithelial cells are more susceptible to apoptosis. Hence, due to this only in electron microscopy there will be a tubular epithelial cell apoptosis, and also tubular after apoptosis, this tubular epithelial cell will be transformed into myofibroblast, that is mesenchymal interstitial fibrosis. So most common cell that is damaged in obstructive injury is tubular epithelial cell, but more resistant to obstructive injury is glomerular cells. Again, this is a question asked in an exam. So more sensitive. So in initial renal damage, what is the most sensitive marker? Means we know in clinically in any renal tubule, any kidney function is lost, there will be a rise in the creatinine. But even before the rise in the creatinine, most sensitive and early marker for a renal tubular damage is urinary interleukin 18 level will be increased. This also asked. So at microscopy level, most common cell damaged in obstructive renal injury is renal tubular epithelial cell, and most resistant cell is glomerular cells, and most sensitive marker for renal tubular damage is increased urinary interleukin 18 levels. So this is the pathophysiology. So as I previously told, whenever there is an obstruction, angiotensin II will be released. This will recruit all lymphocytes and monocytes. From this, growth factors will be released. This growth factor, what will do means, this will particularly affect the renal tubular epithelial cell, because this is the cell most commonly damaged in obstructive injury. Yes, as I said, this cell will go for either apoptosis, or either this cell will be converted into myofibroblast, and more collagen will be deposited and ultimately lead to sclerosis, that is glomerular sclerosis of the kidney. This is the most important pathophysiology features seen in obstructive injuries, tubulointerstitial fibrosis. So coming to what is the clinical impact of this urinary tract obstruction? So, so hypertension is the most common clinically we will see in case of chronic kidney disease. Patient will have elevated BP. This is more common in bilateral compared to unilateral, because in unilateral normal kidney will be functioning normal, hence there will be no hypertension. Why this hypertension is occurring in bilateral means, because it is due to volume mediated mechanisms. Already told, in bilateral urinary obstruction, no urine will be there will be patient will be present with acidosomia, anuria. So all intravascular volume will be raised. As a result of this intravascular volume raised, hypertension will be there. However, hypertension in unilateral urinary tract obstruction is due to renin-angiotensin upregulation. So compensative, these are all the common. What will happen in case of unilateral urinary tract obstruction? There will be a compensatory renal growth. If one side kidney is not functioning, means other kidney will take over the function. So there will be a contralateral hypertrophy will be there, not hyperplasia. Hypertrophy we know that as cell size will be increased, but hyperplasia is the number of the cells will be increased. So this compensatory renal growth is particularly for unilateral urinary tract obstruction, not for bilateral urinary tract obstruction, and this is mainly mediated by insulin derived growth factor 1. So these are the factors influencing the renal function after the relief of either a unilateral obstruction or a bilateral obstruction. So after the relief, so what these are the factors that will influence the renal function. One is duration and severity. As I already told, either it is a unilateral obstruction or a bilateral obstruction. Bilateral, there will be more damage. Unilateral, there will be less damage. And in also in unilateral, if you are not going to treat after more than 24 hours, again the damage will be more. And again, age of the patient, again based in RP, all these factors will influence how he is recovering from the obstruction. So, what will happen when if you are not treating more than 2 weeks of the obstruction? What will happen is there will be all complete loss of the kidney function will occur, and there will be an increased risk for hypertension. And as I already told, why this complete loss of function is there will be a persistent vasoconstriction occurring at the afferent arterial level. So this is the one model that developed by Vaughan et al. What he told is in unilateral obstruction, if you are going to treat within 7 days, there will be 100% recovery. If you are going to treat within 14 days, there will be even you are treating 70% will be recovery. But after 6 weeks, if you are going to treat an obstruction, even if you leave the obstruction, there will be no recovery of the function. That is, there will be no recovery of the glomerular function and tubular function. So the ideal time is within 7 days you should treat the obstruction. So there will be 100% of recovery of both glomerular function and tubular function. So what is the pop-up mechanism? Pop-up mechanism, if you are not going to relieve the obstruction, what will happen? Kidney will try to pop up. That is, somewhere it will be opened up. Either in the either the obstructed urine will go to the lymphatic channel, that is pyrolymphatic flow. Either that obstructed urine will transmit to venous, the venous channel, that is called as pylovenous flow. Fornicial rupture means we are not going to treatment, the calyx will be ruptured and patient will present with urinoma, that is fornicial rupture, and last is tubular reabsorption. These are not much important. Coming to important is next is post-obstructive diuresis. This is also very important from exam point of view. What is post-obstructive diuresis? For example, if a patient comes with stone disease, you are treating a stone, and after the treatment of stone disease, what will happen in post-operative period? Patient will develop significant polyuria. When we will go for rounds and we will see the urine output, they will be written in chart as 6 liters, 7 liters of urine output. Within 1 day, there will be 6 liters and 7 liters. This is called as post-obstructive diuresis. There will be more than 200 ml per hour. There will be polyuria will be there. See, as I already told, this polyuria will be more common in bilateral urinary tract obstruction. You remember this post-obstructive diuresis is not a pathological process, it's a physiological process. Why it is happening? In case of bilateral, as I already told, there will be a down regulation of aquaporin channel. As a result, there will be polyuria will be there, and also there will be sodium transport channels will be reduced, so natriuresis will be there. So there will be a polyuria will be there, and also there will be an increased COX-2 expression. All these three factors is responsible for the increased urine output. That is, there is a significant polyuria in post-operative level after you are treating a bilateral urinary tract obstruction. These changes, these POD, that is post-obstructive diuresis, also seen in unilateral obstruction, but as already told, this is more specific for all changes are more specific for bilateral urinary tract obstruction. So usually these patients do not demonstrate any signs and symptoms, because as already told, this post-obstructive diuresis is not a pathological diuresis, it is a physiological diuresis. But we need to monitor these patients closely, because as I already told, there will be a polyuria and there will be sodium loss. If more sodium loss, what will happen? The serum sodium will be more less than 120, and patient will go for confusion. Yes, in post-operative, we should allow the patient to early oral fluids should be allowed, because there will be significant loss of volume in the urine. We should allow him to take adequate amount of oral fluids. This is the main treatment in case of post-obstructive diuresis. But there is no specific drug to treat post-obstructive diuresis. Only fluid management is important. But recently, COX-2 inhibitors and sildenafil are tried for the treatment for post-obstructive diuresis. And then coming to the general management of a renal obstruction. Whenever a patient comes with a renal obstruction, what we will prescribe? Usually we prescribe some diclofenac or something else, but it should not be given. The commonly given drug is either a NSAID or a COX-2 inhibitor. What will happen means both have different mechanism of action in decreasing the pain. One in NSAID, what will occur? There will be a renal blood flow will be decreased. As a result, collecting system pressure will be also decreased. Hence, there will be a relief of pain. But in case of COX-2 inhibitors, what will do means it will act at the glomerular capillary level, where the hydrostatic pressure will be reduced, thereby reducing the pressure in the collecting system and thereby decreasing the pain. And another one is alpha blocker. This is mainly for stone crystallization, as already not particularly used for distal ureteric calculus. And what is the role for emergency percutaneous? The PCM means percutaneous nephrostomy means if there is an obstructed system, bilateral obstructed or either a unilateral obstruction, a patient and also patient is present with sepsis, particularly pyonephrosis or infected system, patient is not tolerating any procedure means emergently we will put a PCM so that we will divert the urine, and after once the patient recover from the sepsis, we will do a proper procedure to relieve the obstruction. So what is the role for nephrectomy in case of obstruction means, as I already told, when you are not going to treat either a unilateral obstruction or bilateral obstruction, even after 6 weeks, the kidney function will almost gone. Whenever there is a function is less than 10% on a DTPS scan, this is an indication for nephrectomy, where there is no role you are going to relieve the obstruction or not, because the kidney function is almost lost. So nephrectomy is indicated whenever there is a 10% of overall renal function. So that is about the physiology of the urinary tract obstruction. So the thing in exam, what they will ask, and previously what questions asked is two things only. In unilateral urinary tract obstruction, what it will happen? As I already told, unilateral urinary obstruction, there is a triphasic pattern: phase 1, phase 2, and phase 3. In phase 1, there will be a vasodilatation, which is due to nitric oxide and PGE2, so that the renal blood flow and GFR will be maintained. But in the same in phase 3, what will happen? This all compensating mechanism will be lost. As a result, there will be a decrease in the renal blood flow and GFR. But this classical pattern is not seen in bilateral urinary tract obstruction, where from the start of obstruction itself, there will be an apparent arteriolar vasoconstriction will be there, and also important mediator. In unilateral, important mediator is vasodilator. In bilateral, the important mediator is A and B. This is also again the questions asked. Important mediator responsible for the changes in bilateral urinary tract obstruction is A and B, that is arterial natriuretic peptide. As a result of this peptide only, these patients in bilateral urinary tract obstruction, after the relief of obstruction, patient will develop polyuria, patient will develop natriuresis. Is concentrating, that is urinary acidification and concentrating ability will be lost. All are more common in bilateral urinary tract obstruction compared to unilateral urinary tract obstruction. Usually these questions only is asked, and also the more common cell injured in obstructive renal injuries, tubular epithelial cell, and most important pathophysiological change occurs tubulointerstitial fibrosis. Remember, these 2 or 3 questions only previously asked. So that's all. We are coming to the end of the pathophysiology of the urinary tract obstruction. Then we will move on to what are the causes of a urinary tract obstruction and how we are going to treat. Okay, next we will okay. Next we are moving to what are the causes of urinary tract obstruction. Most common is a PUJO, that is a pelvic junction obstruction, and other is a stricture disease in the urinary tract, and how they are diagnosing and how they are treating. So from PUJ also 1 or 2 questions will also they will ask. I will tell about the entire chapter, but I will tell what are the important things. As I already previously told, in unilateral in pathophysiology obstruction, there are 2 types: one is unilateral and bilateral. That is the area where the question is asked, and also in PUJ also there are few areas where they are usually questions will ask, and that area I will focus and I will tell, and you can make a note of it so that it will be useful for the exam. So coming to the urinary tract, upper urinary tract obstruction. So we are going to speak about two diseases. One is PUJO and another one is a stricture disease. PUJO means pelvic-ureteric junction obstruction, which is also called as uretero-pelvic junction obstruction. So what is PUJO? PUJO is nothing but this is the obstruction at this level, that is uretero-pelvic junction. There will be an obstruction. As a result, urine is not going. This is called as PUJO. Simply remember, that's all. So this UPJ, that is this PUJO, is more commonly detected in case of antenatal scan. This is yesterday the pediatric urology they will thought most common antenatal hydronephrosis 50 to 60% there will be a transient urinary tract dilatation, and 10 to 30% there will be an PUJ obstruction, and another 10% will be due to VUR and posterior urethral wall, which are all teached in pediatric urology. So that is the they have written in PUJO is commonly seen in 10 to 30% of the antenatally detected hydronephrosis, and PUJO is more common in male, and left kidney is more commonly affected, and bilateral PUJO will be seen in 10 to 30%. These are all facts. Just to remember, they may ask. So what are the causes of they can be classified either as a congenital cause or acute cause. Another one is intrinsic and extrinsic. These are all not much more important for exam purpose. Just remember there is a congenital cause and another one is acute cause. Congenital, where there will be a functional and adynamic aperistaltic segment of the ureter will be there due to intrinsic stenosis, kinks, angulations, adhesions, lower pole artery, and eye incision of the pelvis. Eye incision of the pelvis means nothing but ureter. Normally, it will join in a different position. An eye incision of pelvis is ureter will go and it will join in the above the pelvis. That is called as eye incision of the pelvis. Acute means PUR, tumor, and fibroepithelial part. Not much more important. This is a one way of class causes. One either is a congenital or acute. And another way of classification is either PUJO due to an intrinsic obstruction or extrinsic. What is intrinsic? Intrinsic means due to ureter itself. Extrinsic means from outside the ureter. So intrinsic means there will be an aperistaltic segment. There will be some aperistaltic segment in the ureter, so that urine can't able to propagate the peristalsis across the UPJO. But remember, this aperistaltic issue, very well remember this. The intrinsic narrowing is due to aperistaltic segment is there. But however, caliber of the ureter will be normal. You can able to calibrate the PUJ with 14 French or 16 French ureteric catheter, but there will be no peristalsis because that ureter peristalsis will be lost. That area of the PUJ peristalsis will be lost, but however, the diameter will be normal. So only they are coined the term for this intrinsic narrowing as a functional obstruction. Why this aerodynamic segment is occurring? Normally we know in ureter there are three layers. One is outer longitudinal, middle circular, and inner longitudinal. Here what will happen means this middle circular fiber will be lost and it is almost replaced with entire longitudinal muscle, and also there will be an abnormal deposition of the collagen. Due to this changes only, there will be an aerodynamic segment. As a result, there is no failure to propagate the peristalsis across the PUJ. What is extrinsic? Extrinsic means anything compressing from the outside. The more important what we are worrying about in outside compression is an accessory lower polar renal artery. That what's as already we know that a configuration in the pelvis is first is vein, next is artery, and last pelvis is usually posterior. So in any case, whenever there is an aberrant lower pole renal artery, it will compress the UPJO level. So it will cause an obstruction. This aberrant renal lower pole accessory renal artery may cause up to 20% of the UPJO obstruction. So you can see in this figure where there is an aberrant lower polar artery, it will compress the ureter at the PUJ level, leading to PUJ, that is a pelvic junction obstruction. So then coming to the presentation in neonates, as what they will present, usually they will present with hydronephrosis because they can't able these child will not tell pain, mass, anything. Usually the parents will come and they tell the child is not feeding well properly. There is a constant the failing to cry. These are all the symptoms will be explained by the parents. But when we do ultrasound, what we will see there will be a hydronephrosis, not a ureteronephrosis. Remember, PUJO is a hydronephrosis. It is not a hydroureteronephrosis. There will be only dilation of the collecting system, not the dilatation of the ureter. So hydronephrosis, where the AP diameter of anything more than 12 mm in when the pediatric patient, it's a significant obstruction is present. So these are other this flank mass, intermittent flank pain, hematuria. These are all presented by some old children and adults. Adults usually present with intermittent on and off flank pain will be there. There will be sometimes there will be a palpable flank mass will be there. Sometimes patient will present with hematuria. This hematuria, why is occurring is the collecting system will be usually dilated. As a result of dilatation, that all the mucosal capillary vessels will break and they will bleed, and so there will be a thin hematuria will be there. And another is Dittel's crisis. This we will know whenever a patient taking increased amount of fluid intake, this will lead to a sudden onset of pain, because when the patient taking the increased amount of fluid, what will happen? There will be a diuresis will occur, but there is a obstruction. But kidney can't able to propagate the urine. They will develop a back and flank pain immediately after taking increased fluid intake, which is called as Dittel's crisis. And the other presentation may be UTA, hypertension, abdominal mass, not much more important. This is more important. This associated anomalies. So more. This is also again the question asked. Most common renal anomaly associated. Most common anomaly associated in PUJO obstruction is renal dysplasia. Though these all anomalies are seen: renal multicystic dysplastic kidney, renal agenesis, PU or vesicouretic reflex, osteocony, even Batter anomalies are also associated. But most common anomaly associated in PUJO is renal dysplasia. This you remember. This also again exam question asked. Renal dysplasia is the most common congenital anomaly usually presenting with PUJO. And a VUR, that is vesicouretic reflex, concomitant vesicouretic reflex, and PUJO will be present in 40% of the individuals. So if you are not going to treat a PUJO, what will happen? This is the complication? Infection will occur. Secondary stone formation will be occur, and these patients are increases susceptibility to trauma, because in these patients the kidney will be ballooned out, because due to obstruction the kidney will be enlarged and they can able to perforate. So when they suddenly fall, they are more susceptible to trauma, and ultimately they will lead to, when you are not going to treat the PUJO obstruction, will lead to hypertension and renal failure. So coming to the investigation, what is the investigation? How will you diagnose a PUJO obstruction? Whatever we saw is a presentation. In neonate, parent will tell the history that the child is failure to drive, crying, not feeding properly. Adult will present it, flank pain, loin mass, or even hematuria, or even urinary tract infection. So what is the investigation we are going to do? In all cases of urology, first investigation as a urologist we will use ultrasound. So ultrasound, what you will see in ultrasound? Ultrasound, there will be an hydronephrosis, dilatation of the collecting system. Remember, PUJO, in PUJO, only collecting system only will be dilated. That is collect only pelvis, calyces only will be dilated. There will be no dilatation of ureter. If ureter is dilated, that is hydroureteronephrosis is documented in ultrasound, then your PUJO is it is not a PUJO. Then your diagnosis should be changed. So the important finding, what you see in PUJO, there's an hydronephrosis, because obstruction is the level of PUJO. Distant to the obstruction, you can't able to see the ureter at all. Hydronephrosis is the most common finding in the ultrasound, which is a feature of the PUJO. And also in pediatric urology, they may thought how will you different? This also previously exam question asked. How will you differentiate PUJO and multicystic dysplastic kidney? As we know, pediatric urology, they will thought that in multicystic dysplastic kidney, what will be there will be multiple rounded cysts will be present, and they are not communicating with each other. But in PUJO, there will be centrally there will be a pelvis and surrounded by a multiple small symmetrically arranged calyces, that is representing the calyces, and they will be connected to the central pelvis. But in multicystic, there will be no connection in between them. This is the difference between the multicystic dysplastic kidney and PUJO. So this is the grading, not much more important. So the hydronephrosis, initially there is no calyceal dilatation, that is grade 1. Grade 2 is major callus alone dilated. Grade 3 is minor callus also dilated. Grade 4 is entire collecting system is dilated, and also parenchyma will be thinned out. This is the grading of the hydronephrosis. What is the significant in antenatal period? This is also pediatric in urology they thought, but just I telling. In the significant hydronephrosis, this is also exam question asked. What is the significant hydronephrosis in antenatal? These are all ultrasound parameters, where there will be an APRD, means anterior posterior renal pelvic diameter. This diameter will be more than 10 mm after 24 weeks of gestation. It is a suggestive of significant hydronephrosis. That is, that child will have some significant hydronephrosis to be present, and they later may develop into a PUJO. And also the ratio of the AP diameter of the pelvis to kidney. That is, pelvis diameter is more than 0.5. Ratio is more than 0.5, and also calyceal dilatation. All these three factors are suggest there is a significant hydronephrosis in antenatal period. So coming to IVU, usually IVU means intravenous urinogram. For diagnosis, usually nowadays we are not using IVU because all IVU are replaced by a contrast enhanced CTKV because of the superior imaging superiority. So IVU is not used just for finding. We are for some classical finding we are doing IVU. What you will see in IVU means there will be a non. This is the more important. You should not visualize the ureter in PUJO. If you visualize the ureter, it is not a PUJO. So there will be no, when the contrast they will be given. What will the contrast? The contrast will be pulled in the collecting system. So that is the marked pylocalcitosis, and there will be narrowing of the PUJ will be seen, and there will be no visualization of the ureter. And all contrast, whatever the contrast you are giving in intravenously, all will going to be accumulated in the collecting system, even on delayed. So there will be no visualization of the ureter. So in ultrasound, only hydronephrosis. In IVU, there will be no visualization of the ureter. So, what is the investigations of the question is the investigation of choice in UJOs, though ultrasound and IVU are initial screening test. Investigation of choice is contrast enhanced CTK is the investigation of choice. What is the typical finding in UJOs? As I already told, there will be an hydronephrosis without a dilated ureter. Whenever there is a hydronephrosis, but we are not seeing the ureter, then it is a you should think about UJO. So you can see in this picture where there is a marked dilatation of the collecting system. Even that minor calyces is also dilated and parenchyma is also thinned out. You can see again the picture. You can see there is an abrupt cut of the arrow marks, abrupt, but distal to that you are not going to see the ureter. Only there is a huge dilatation of the pelvis. Even the calyces are also dilated, but there is distal to that there is non-visualization of the ureter, which is a classical finding of the PUJO. So this is the, for adult we will do either ultrasound or CTKV. Usually BCUG, that is MCU, will not do for adult. It is only for children because, as already told, concomitant VUR and PUJ will be present in 40% of the children. To diagnose this only, we are doing BCUG, but this BCUG is not important for adults. This may be already told in pediatric urology. So coming to diuretic renography, this is called as diuretic renal scan. So you are diagnosed. So a case of PUJ comes, you diagnose PUJO. You are diagnosed the PUJ. This is whether this PUJ need to intervene, need to operate, need to either the kidney is functioning or not. How you determine? This is based on by this renal scan only. So CTKUD is only to diagnose a PUJO. But whether you need to intervene the patient or you no not need to intervene the patient depends upon this scan. So all PUJO, once you diagnose, they will order a renal scan. That is the right diuretic renal scan. So this also already we taught in uroradiology class. There are two types of diuretic renography. One is technetium 99 DTPA and technetium 99 MH3. This you know DTPA, that is diethylene triamine pentamic acid, is a glomerular tracer which is handled by the glomerular, and the MAG3 is handled by the tubular. So the question again asked is most common renal scan done in PUJO is DTPA. Commonly we are doing in all over India. Common diuretic renal scan for PUJO we are doing is DTPA. But question what asked is what is the ideal agent means? It is MAC3, but we are not doing MAC3. Why? Even though it is an ideal agent, why we are not doing? Because it is costly. Still now this reagent is not available in India. So most commonly done renal scan in PUJ was DTPA. But when the question is asked, what is the ideal agent to measure a GFR and drainage is MAC3. So based on the question, answer will be different. So another advantage in MAC3 is it can be done even in renal insufficiency patient, even if the patient's absolute contraindication to do this diuretic renogram is whenever the creatinine level is more than 3 milligram. But the advantage in MAC3 is it can be done even in renal insufficiency patient also. So most common investigation done to find out the function of the PUJO is DTPA. Ideal agent is used is MH3. So in this diuretic renal scan, what you are going to see, what are the parameters you are going to look, and how you are going to take. Simply I am telling there are three important parameters that you are going to see in this scan. to assess the that is drainage, whether the kidney is draining or not. Only we are going to operate. So three, one is T max, another one is T up, and another is time activity curve. What is T up? In diuretic urinogram, what they will do, they will give the radio tracer in the intravenously, and then they will take serious tests whether the kidney is excreting that excreting this DTP or MPGT. So the three important parameters: T max, T up, and time activity curve. The T up means time taken for the 50% of the contrast to remove. Normal is less than 10 minutes. Anything more than 20 minutes, it is a suggestive of PUG over there. There is a significant obstruction is there. That is more than 20 minutes is obstructed energy. What is time activity curve? There is one curve will be seen. They will be plotted in the renal scan. The curve is called as Urinary curve. Don't remember much more these things. There are 4 types of curve. The type 2 curve is significant for PUG also. The question is asked which curve, time activity curve will be seen in renal scan in PUG is type 2 curve. Type 1 is normal. And what is the T max value is more than, remember these 3 only. 3 parameters are looking: T max, T up, time activity curve. More than 20 minutes T up is a PUGO, and type 2 curve is the indication of a PUGO. That curve name is called Urinary curve. So this is the 4 curves, where this is the normal pattern. This is the type 2 curve. This you remember, this type 2 curve is specific for PUGO. The question is which curve in renal scan is specific for PUGO is type 2 curve. This is how the renal scan picture will be given, where you can able to see this is the Urinary curve where we are seeing. Here you can see means this is the red color. What there is a normal kidney. That is after contrast administration, contrast is the excreting. The slope is coming down, but is the blue color is a obstructed kidney, where that even after the contrast is given, the contrast is staying in the collecting system. It is not at all, the slope is not down. Not much more thing you don't need to know about this. Just remember, type 2 curve is specific for obstruction, and anything T of more than 20 minutes in this renal scan is a pattern for obstructed drainage. So what is Whittaker-Test? Before the invent of this renal scan are invented nowadays. So before the invention of renal scan, how they identify the upper tract dilatation is called Whittaker-Test. This is only for historical purpose. Nowadays, this Whittaker-Test are not at all done. Just for exam purpose, we are teaching this Whittaker-Test. What is Whittaker-Test? Same thing. What will done is, under the CM guidance, they will put a PCN catheter in the renal pelvis, and they will connect to a pressure transducer, and via the PCN tube they will inject the saline at the rate of 10 ml per minute. If and then they will monitor the pressure in the pelvis. If pressure in the pelvis is less than 15 centimeter of water, it is normal. If it is more than 22 centimeter of water, it is obstruction. If anything between 15 to 22 centimeter, it is called echo. So Whittaker-Test, remember, it is not done nowadays. Only used to evaluate upper tract dilatation. Previously, where when renal scan, that is diuretic renal scan or nuclear scan is not available. Nowadays, this Whittaker-Test is not done. If pressure of more than 22 centimeter of water is significant for obstruction. So we are diagnosed the PUGO. How we are going to treat? So the investigation of choice in PUGO is CCTKB, but whether to operate or whether to remove the kidney depend upon the renal scan. If the renal scan shows a good GFR, that is, as already told, when the split function is very good, that is more than 20% means we will operate. That is, some pyeloplasty will be done. But if it's, as already told, when there is less than 10% of the kidney, remember, for all conditions, whenever a kidney is less than 10% function, there is no role for any treatment of treating that disease. The treatment, ideal treatment is nephrectomy, because the kidney is almost lost its function. That is indicating of less than 10%. So only for more than 10% and GFR maintained, only we are going to tease pyeloplasty and all the things. So coming to the management, so what is the indication for intervention? So you diagnose the PUGO and you do a diuretic renal scan. So what are the indication you need to whether to operate or not? Is patient have severe symptom of obstruction. Patients that the renal function is decreased. When you see the diuretic renal scan, they will give GFR, right kidney GFR, left kidney GFR. If you see the GFR is reduced, this is going to be reduced, means that is an indication that you need to intervene the patient. And also there is a progressive impairment of bilateral renal function. Sometimes PUJO associated with stones, associated with infection, patient developing hypertension. We can see in ward where there will be a 24-year male, but you have a severe hypertension, but we evaluate there will be a PUJO also. All these are all the indications to treat surgically to treat a PUJO. Presence of symptoms, there will be a decrease in the renal function, which is documented in diuretic renal scan, nuclear scan, development of stones or infection, hypertension. All are indications for intervention. So then coming, so what is the treatment of choice? What is the surgical procedure of choice for PUJO is pyeloplasty. It can be either done in open or lab. Remember, there are two types. One is dismember, another one is non-dismember. Dismember means just separating the PUJO. That is called as dismember. Non-dismember means they are not separating the PUJO. Without separating, they are doing operation is called as non-dismember. So in dismember, two procedure. One is modified Anderson-Haynes dismembered pyeloplasty and another is reduction pyeloplasty. So most common procedure done for PUJ is Anderson pyeloplasty. So the question is most common pyeloplasty done in PUJ was Anderson. It is a dismembered. Dismembered means you are separating the pelvis and the ureter and then you are doing surgery. This is called dismembered. Non-dismembered is not separating, which is all flap procedures, spiral flap procedures, vertical flap. These are all named. Just remember, they may ask Polish plasty, Penz's plasty, that is Haynes Wikiculis pyeloplasty. So, what are the principles of pyeloplasty? This is also important. So, while doing pyeloplasty, what is there are some five important results. The suture should be watertight. There should not be any leak, and it also the suture should not be tension. There should be a tension free and without compromising the vascularity and funnel shaped drainage. These are all the principles of the pyeloplasty. So, dismembered, as I already told, Anderson's pyeloplasty is the treatment of choice. So, what is the advantage is in Anderson pyeloplasty, you can remove all abnormal PUJ. As already told, what is abnormal PUJ? That the adynamic peristaltic segment of the ureter will be completely removed in the Anderson pyeloplasty. And it is suited in all types of pelvis, whether it is high incision or low incision of the pelvis, you can suit. And also even suited in lower pool crossing vessel. Because as already told, lower pool crossing is a one cause for eccentric obstruction in the PUJ. In this moment, what will do? They will separate the pelvis and pelvis and the rest of the ureter, so that the obstructing crossing vessel can be transposed and you can be sutured, so that obstruction can be done. But however, this dismembered pyeloplasty is not ideal. This is also previously asked. These are all contraindication to this type of dismembered pyeloplasty. That is when PUJO is associated with multiple long proximal stricture, small pelvis, small intrarenal pelvis. In all these cases, this dismembered pyeloplasty you can't able to done. But remember, all these will become an indication for non-dismembered pyeloplasty, which we will speak later. So the dismembered is not done in when PUJO is associated with stricture, when PUJO with small pelvis. So this is the classical Anderson. What they will do means this is the PUJ level. They will cut here, they will cut here, they will cut, and they will anastomose. So this is called dismembered. Since they are cutting and removing, that is called as dismembered. They remove the UPJO and they anastomose the rest. You can see they anastomose the rest. This is the classical modified Anderson's pyeloplasty. Remember, this is the treatment of choice where they remove the abnormal PUJO part. And another one is reduction. The reduction is also same principle like Anderson. What in reduction is, since there is a more dilated pelvis, they will suture the proximal cranial part. They will suture some off of the pelvis, and rest they will suture. Similar to Anderson, that just they are reducing the pelvis, so it is called as reduction pyeloplasty. So coming to this non-dismembered, these two only dismembered, which are this dismembered only we are routinely doing in our practice. Routinely doing surgery is dismembered, either a modified Anderson pyeloplasty or reduction pyeloplasty. All this non-dismembered, that is Polish YV plasty or flap procedures, we are not doing. Only in special conditions and situations we are doing. Where we are doing this Polish VI. What is Polish VI plasty means? Nothing. This is the PJO. They will make a YV shaped incision. They will start an incision from the ureter, and like Y, they will put one incision, and another they will put incision. They take this lower flap and they will suture here and make a VY plasty. This is Polish VY plasty, but this VY plasty is a non-dismember. Remember, this is not dismember. Why not dismember? We are not transecting, we are not dividing. Just you will create one incision, you take a flap and we are suturing. So it is a non-dismember type. And absolute contraindication, all these flap procedure. Remember, as in dismember, the absolute contraindication in dismembered is when PUJ is associated with the strictures and PUJ associated with the small renal pelvis is an absolute contraindication for dismember. But absolute contraindication for a non-dismembered is any presence of crossing vessel, because if there is a crossing vessel means that is the reason for obstruction. Without dismembered, how you are going, how you will treat it. So this non-dismembered is absolutely contraindicated for crossing pelvis and redundant pelvis. So this is another spiral wall, cut the spiral wall technique, where nothing, they will make one incision, make one spiral flap like incision. They bring this, they 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 bring this flap downwards and create anastomosis. As already told, all flap procedures and all non-dismembered procedures are absolute contraindication is a vessel crossing. These flap procedures, as already told, what are the contraindications for a dismembered will become an indication for spiral. Whenever a PUJ is associated with the wrong proximal stricture, this flap will be used. Same, this is a spiral flap, and this is a vertical flap, which is called as carriendo. Where they make a spiral, here they make just a vertical, and they will bring this flap downwards and they will suture, particularly used in box shaped renal pelvis. Again, contraindication for flap procedure is when there is a lower pole crossing vessel is an absolute contraindication for this flap procedure. What is Davis? These are all much more important. Davis intubated means thus there will be a long stricture will be there along with the PJO. There will be a long stricture. So this much length we can't able to anastomose. So what they will do means they will incise and they will take a flap as much whatever the flap coming. They will suture. They will put a stent and leave it open. This will heal by secondary healing by ureteral regeneration. This is called as Davis intubated ureterotomy. What is Fingers spinoplasty is similar to Haynes McGuinness. What we done in congenital hypertrophic pyloric stenosis. They will do a horizontal incision in the second part of the duodenum and horizontal incision in the pylorus, and they will suture it longitudinally. Same principle is also like this. They will incise longitudinally and then they will close horizontally. That is called as Spencer's pyloplasty in principle. So Hellstrom procedure is also not. This is vascular. What is Hellstrom? This is also again asked. What is Hellstrom procedure? Hellstrom procedure is done in which condition? Usually the question is asked not about this. Hellstrom procedure is done in which condition? Which is done in PUJO. PUJO is the disease where this Hellstrom procedure, which is also called as vascular reach. As I already told, this lower pole crossing vessel sometimes may be responsible for PUJO. What they will do means they will take this, they will dissect and they take this lower pole and they take this renal lower pole crossing vessel and they transpose above the pelvis and tackle it. This is called as Hellstrom procedure, just vascular transposition of the lower pole crossing vessel just above the pelvis. This is the done in PUJO. So ureterocalicostomy is a salvage technique when all procedures are failed, multiple surgery where there is no ureter and no PUJ at all. They directly bring the ureter and the anastomosis to the lower calyx, which is called as ureterocalicostomy. Then lap. This all open procedure can done in a lap. In lap, the most common procedure is dismembered, and success rate is almost equal. Both in open and lap, all success rate is almost equal only. So most common complication in PUJ repair is anastomotic urine leak. As I already told, the principles of pyeloplasty is we should tight a watertight, tension-free anastomosis. Whenever it is not a watertight, so most common is anastomotic leak and urinoma formation is the most common complication. So we finished up the open procedure. What is the endourology procedure for PUJ work? This endourology is not as much success. As I already told, both the lap and open procedure have 90% success, but endourology is not much more success, only up to 70% of the success rate, and only in specific conditions only we can do endourology. And what are the specific conditions? I will tell briefly. So what are the endourology available is percutaneous antegrade endopylotomy. In antegrade means you are coming via the pelvis. Endopylotomy means via endoscopy. Pylotomy means you are cutting the pelvis. That is the meaning. Antegrade means coming via pelvis, via endoscopy, and pylotomy means you are cutting the pelvis. What is endopyloplasty means? This is also in antegrade technique. You come via endoscopy and do pyloplasty like laparoscopy. In endoscopy itself, nephroscopy itself, they will suture. That is called as pyloplasty. What is retrograde endopylotomy means? This is antegrade where we are coming from pelvis. This is from retrograde. From the bladder, we will go via ureteroscope and we will do a endopilotomy. Endopilotomy means incising the pelvis. And another is retrograde cautery wire balloon endopilotomy, not much more important for exam, which is called as success. As already told, success rate is less, only 70% compared to open and lap, and only for specific conditions only all these endoscopic procedures are done. Just to remember, this antegrade endopilotomy, this is the antegrade where they will put a puncture the kidney, they put a nephroscope or anything particular scope, and they put a guide wire and they will cut this region. The endopilotomy, they will cut the that obstructed PUJ part, they will cut. This also again question asked, this endopilotomy, how you will cut? The how you will, you should cut a full thickness manner. You should not, as already told, ureterus, mucosa, inner longitudinal, middle circular, and outer longitudinal. You should cut full thickness. That is, you cut the entire ureter such that the outer periurethral and peripelvic fat should be seen, such that you should cut. And where you should cut? Either you cut medially or laterally. This is also again the question, exam question, as already told. Always the cut should be lateral part of the ureter, because from the medially only blood supply of the ureter will come from the aorta and the gonadals. So you should not cut the medial part. If you cut, what will happen? There will be a torrential bleeding will be there. So always endopilotum should be in the lateral part of the lateral part of the ureter, and it should be a full thickness. You should cut mucosa, you should cut all the layers of muscle such that the outer peripelvic fat should be seen. It can be cut either in a cold knife without energy source, or it can be used either using a laser also. This is endopilotum. This can be either done in this endopilotum, either done in antegrade. This is antegrade approach, where we are approaching from the kidney. Retrograde approach is nothing but you are approaching from the bladder. You put a ureteroscope, you will go along the path of the ureter and you will cut here. This is the endopilotum, either used via antegrade approach or retrograde approach. What is percutaneous endopilotomy? This is a hybrid technique. Nothing combining endopilotomy and endoscopic plasty. What they will do means in endopiloplasty, they will cut. Then they will suture what in this area itself, like laparoscope, they will have some special instruments will be there. They will put the suture material here, then they will suture like Penze's pyeloplasty, where they will cut longitudinally and they will close horizontally. That is the percutaneous endopilotomy, which is an hybrid technique, combining a percutaneous endopilotomy and along with endoscopic Penzer pyeloplasty. As I already told, this is a retrograde, where along one is antegrade, from the kidney we are coming. Here, from the ureteroscope, we are passing into the ureter, and we will cut. Remember, where you will cut, you will cut in the lateral part. And how you will cut, you should cut the entire. You can see the entire, even mucosa, submucosa, all muscle layer should be cut up to you are seeing the peripelvic fat. Till level, the endopilotum should be done. So this is the endoscopy procedure. So what is the indication for emergency PCN? So in the case of PUJO, what is the role for percutaneous nephrectomy? Just a PCN, what is the indication? Whenever a patient presenting with acute infection, PUJO with sepsis, PUJO with azotemia, compromised renal function, PUJO in a solitary kidney, bilateral PUJ. These are all the indication where we will put just a PCN. We will not treat immediately these patients, because if you immediately treat this patient will go for urosepsis. So to relieving the sepsis and to improve the patient, we will put an emergency diversion PCN for these 4 conditions. We will do an emergency PCN, but this is not a treatment. This is just the emergency. You are relieving the obstruction in case of PUJO. So what is the role for stenting? Whether stenting alone improve the PUJO? The question may be asked. Whether stenting, no role for stenting. You can take, sir, only there is obstruction is there. Why you are doing all the procedure? Put a stent, it will treat the obstruction. No. There is no role for only URS and stenting in PUJO, because it will not cure the disease. PUJO is a disease where there is either intrinsic obstruction or either extrinsic obstruction. So putting a stent will not cure the disease. It may relieve the obstruction, and also putting a stent will also complicate the upcoming surgery. So there is no role for only stenting in case of PUJO. So as already told, VUR is almost associated in 40% in PUJO. This may also be treated in told in pediatric urology. So when a patient have both VUR and PUJO, what you do first and what you treat first. So in this scan, always you do a renal scan. As already told, investigation of choice in PUJO is CCTKB. After CCTKB, you will do a PUJ, you will do a renal centigram. That is the nucleus scan, DTPA. If there is PUJO, you do a pyeloplasty first and then the VUR treatment. If there is no PUJO, then you have to treat the VUR first. So when both VUR and PUJO is present, which is treated first means PUJO is treated first. VUR should be treated after the pyeloplasty. there is no PUJO, you can treat the VUR. So correction of the upper tract obstruction is more important when there is both VUR and PUJO, because if you correct the VUR, what will happen is that post-operative edema will again worsen the upper tract dilatation. So only initial VUR correction should not be done. So whether we can do simultaneous correction, no, simultaneous correction also should not be done, because it will compromise the vascularity of the ureter. So whenever the VUR is associated with PUJO, always treat PUJO first and followed by VUR. So this is the PUJO part. So in PUJO, they won't much more. The important area where they will ask in PUJO is the investigation of choice is CTKB and the nuclear scan, or which scan we will do. Remember, the most common scan in PUJO is DTPA, but ideal scan is MAC3 scan. So ideal agent to find the GFR in the case of PUJO is MAC3, and there are two types of surgical procedure. One is dismembered, and another one is non-dismembered. And dismembered is most commonly we are doing in routine practice, which is called as modified Anderson spinoplasty. Non-dismembered are all flap procedures and flap procedures and other VY plastic procedures, which are done only in specific conditions. So coming to how we are treating the ureteric strictures, that is upper ureteric or distal ureteric, mid strictures. These are all some of the causes, not much more important for exam purpose, or malignancy, calculus, radiation, ischemia, periurethral fibrosis, infection, all cause ureteric strictures. So again, the management of ureteric stricture, either endourology or open surgery. So either for stricture disease, we can put a stent. For PUJO, don't put a stent. So in stricture disease, we can just put a stent if possible. Possible put a stent. That stent alone will cure 88%. Otherwise, retrograde balloon dilatation. That means they will put a retrogradely, they will put a scope, put a balloon in the area of stricture, and they will dilate so that stricture will be treated. And another is endoureterotomy, same like endophylotomy. Another is same endoureterotomy. But remember, all these endourology purpose procedures are done only for less than 2 centimeter stricture. If the stricture length is more than 2 centimeter, means there is no role for endourology purpose. Only you should go for open surgery. Only is less than 2 centimeter, that is 1 centimeter or 0.5 centimeter, means we can do either stenting alone or balloon dilatation or endoureterotomy. And also is so absolute contraindication for this. Also again question asked, absolute contraindication for endourology procedure and stricture is any stricture length more than 2 centimeter, active infection and also bleeding. There is a coagulopathy are all absolute contraindication for endo procedures in ureteric strictures. So this is the simple way to remember. So when you are seeing a stricture, first you see what is the length of the stricture. If it is less than 2 centimeter, then see location where it is distal ureter, middle ureter, or proximal ureter. So as I already told, less than 2 centimeter, endourology is the best. So distal ureter, anteriorly you incise, mid ureter again anterior, and proximal ureter lateral. This is how you remember is based on blood supply. In proximal ureter, blood supply is coming medially, so you are incising the laterally. In mid ureter, the blood supply is coming from the posterior aspect, so we are incising the anteriorly. In distal ureter also, the blood supply is coming from laterally and posteriorly, so you are incising the anterior. Just opposite to the blood supply, you incise it. That is the treatment. So less than 2 centimeter, you do endo procedure. If there is more than 2 centimeter structure, means then you have to look for the renal function. As already told, whenever there is less than 20% or less than 10% function, there is no role for doing any procedure. Just simply you can do a nephrectomy, because the kidney is almost function is lost. So when its function is more than 20 centimeter and stricture is also more than 20 centimeter, better to open procedure, either in the form of laparoscopy or open procedure. But there is, because success rate is very less in case of more than 2 centimeter stricture disease. So coming to the, we see about the endo procedures. Now we are seeing the surgical procedures. There are 5 different types. One is ureterostomy, that is the stricture part removed, ureter to ureter anastomosis. Ureteroneocystomy, stricture will be removed and ureter will be anastomosed to the bladder. And another one is psoriasis, renal dehiscence. Renal dehiscence means you are all additions of the kidney will be removed and kidney will be mobilized and kidney will be mobilized down. That is called as renal dehiscence. So this also again this area question asked in based on the defect we will choose the procedure. When there is only 2 to 3 centimeter defect, just end-to-end anastomosis. But when there is 4 to 5 centimeter in the distal ureter, we will do resection of that stricture part, and we will anastomose with the bladder. Psoas is up to 6 to 10. I will tell what is psoas and borari flap. Psoas is 6 to 10 centimeter defect, and borari flap is 12 to 15. Usually, the question asked in this psoas and borari flap only. Psoas is particularly done for a length of defect is 6 to 10 centimeter. Borari flap is done for a length of 12 to 15 centimeter. Remember, this two is question asked. Psoas and borari flap. So ureterostomy, as already told, nothing, just removing and end-to-end anastomosis. Ureteroneostomy for lower ureteric defect, that is near to the bladder level. Whenever there is a stricture, we will resect that part and we will do a anastomosis from the ureter to the bladder. So generally, the distal ureteric strictures, that is near to BUJO, near to bladder level, is best managed by either a psoas or borari flap, not a psoas. So this is the end-to-end anastomosis. So psoas, what is psoas is? So this is the psoas. What we will do means this bladder will be mobilized and the ipsilateral bladder will be sutured to psoas minor tendon. So the question is the four important points where the question is asked. What is psoas? Psoas is the ipsilateral dome of the bladder is anastomosed to which psoas tendon? Psoas major or minor? It is the psoas minor. Question is psoas major or minor? It is a psoas minor tendon. While you are suturing to psoas minor tendon, which nerve is going to be affected in the suturing is genitofemoral nerve, because in the, over the psoas minor tendon only genitofemoral nerve will be occur. So while you are taking the bite, while you are taking like that, while you are suturing here, you should take care of the genitofemoral nerve. Otherwise, if you get entrapment, then entrapment nerve neuropathy will occur. So psoas is the ipsilateral dome of the bladder is sutured to the psoas minor tendon. Care to taken not to injure the genitofemoral nerve. The absolute contraindication for this psoas and borari flap is small bladder, because if bladder is very small and contracted, now how we can replace up to psoas minor tendon. So absolute contraindication is small capacity contracted bladder. So this is the ureterostomy, where they simply excise the stricture part and end-to-end anastomosis just for defect of 1 to 2 centimeter. So then coming to borari flap. So borari flap means this is borari flap, where they will take our bladder flap. They will from the dome and the superior surface of the bladder, they will take one flap and they will take the flap cranially and they will tubularize and they will anastomosis to the ureter. This is called as borari. Again, the question important thing is borari flap is done for a defect of 12 to 15 centimeter. But psoas is done for a defect of 6 to 10 centimeter. Borari flap is 12 to 15 centimeter. And they again they ask what is the flap length to base ratio. Flap length should be 3:1 ratio should be there. So flap length to base ratio should be 3:1. And this used to bridge 12 to 15 centimeter. Again, small capacity bladder is a contraindication. What is ideal ureter ideal transposition? In case of extensive ureteral loss, where you can see entire ureter is lost, where you can't able to mobilize the bladder, you can't able to do a psoas, where there is no ureter anatomies, then there is a ideal transposition. We will take on thermal part of the ilium and anastomosis to the proximity and anastomosis distally to the bladder. This is the ideal transposition, where in the case of entire ureteral loss is seen. So this ideal ureter is absolutely contraindicated in case of renal insufficiency. Whenever is a patient with CKD patient, the ideal ureter is absolute contraindication is renal insufficiency with serum creatinine 2 milligram per year. What is auto transplantation? Auto transplantation is nothing last option. If you are not able to do a ideal ureter, means that kidney is like transplantation. You remove the kidney from the pelvis and keep near to the bladder in the pelvis area, and they will switch it. That is called as auto transplantation. So this is the psoas, where the ipsilateral dome of the bladder is switched to psoas minor. Remember, psoas minor tendon, and genitofemoral nerve is the nerve injury. And borari flap is the flap for defect of 12 to 15 centimeter, where they will take the flap from the dome on the superior surface of the bladder, and the flap length to base ratio is 3:1. Remember, 3:1 ratio. So this is the EL transposition, where entire ureteral loss will be there. The absolute contraindication for all this. Then I remember simply for all EL substitution, either in case of in bladder, you see you know about augmentation, in all these cases, absolute contraindication. Whenever patient is a CKD patient, we see the creatinine is raised and total GFR is less than 60 ml per minute. All are contraindicated for this bowel procedures, for this intestinal segmentations. So thank you. So this is the area where they are usually covered in obstruction part. This is the area. One is the pathophysiology, what will happen in unilateral, what will happen in bilateral obstruction. And in case of UJO, simple only, only one or two areas only they will ask. And in urinary structure, they ask about psoas itch, Urology flap, and for which centimeter of defect, which procedure will be done. Only for less than 2 centimeter, only end to end. Apart from that, more than anything 6 to 10, it is psoas. Anything more than 10 is Urology flap is ideal. So this is the area, one or two questions will be asked in this area. And in case of endopylotum, as I already told, it should cut a full thickness structure part, it should be cut in endoscopy. Apart from that, there is much more thing, not much more asked in this pathophysiology of obstruction. So thank you everyone. If any doubts, you can ask in that group so that we can explain and we can tell to you. So that's all. The session of urinary tract obstruction is over. So thank you. Shall we stop the video?
I request all the students to ask the doubts if they have any.
So one student asked about sir, unilateral urinary tract obstruction and bilateral urinary tract difference, please. So as I already told, remember important points in unilateral urinary tract obstruction and bilateral. Unilateral, there will be a classical triphasic pattern will be seen. In bilateral urinary tract obstruction, there is no triphasic pattern. This is one important point. And also in unilateral, initially there will be a compensatory phase, that is due to initially there will be a compensatory phase, that is due to the vasodilators released, particularly nitric oxide and PGE2. What they will do means they will act on the afferent arteriole and they will cause a vasodilation. As a result of vasodilation, renal blood flow will be increased. Since renal blood flow increased, GFR will be increased, hydrostatic pressure will be increased, and GFR also increased. So initial phase in unilateral urinary tract obstruction, that renal blood flow and GFR is maintained. But in phase 3 goes, all this compensatory mechanism will be lost. As a result, what will happen, instead of afferent arteriolar vasodilation, there will be an afferent arteriolar vasoconstriction will occur. Hence, all this GFR renal blood flow will be decreased. In case of bilateral urinary tract obstruction, this triphasic pattern and all not at all seen. As I already told, bilateral is an emergency condition where from the start of the obstruction itself, there will be an vasoconstriction of the afferent arteriolar will occur. So renal blood flow and GFR will start to decrease. And why this is mediated? The question is due to why this is mediated. This is mediated due to arterial natriuretic peptide. Because why it is released means in bilateral urinary obstruction, patient will not pass urine. Patient they will present with azotemia and anuria. So all urine and there will be an increased intravascular volume. As a result of this ANP, that is arterial natriuretic peptide, will be released. As a result of this ANP, what will cause means it will cause apparent arterial vasoconstriction. Hence, renal blood flow GFR will be decreased and there will be no triphasic pattern. And also, after a relief of obstruction in unilateral and bilateral, what will happen in bilateral means
that all that classical tubular changes will happen only in bilateral urinary tract obstruction. That is particularly that the concentrating ability will be lost, sodium will be lost due to sodium channels will be lost, and there will be an aquaporin will be down regulation, means there will be in polyuria and urinary pH will be elevated. These may be seen both in unilateral and bilateral, but it is more common in bilateral because in unilateral opposite kidney is normal and it can able to it can able to maintain the function, but in case of bilateral it is can't able to do in opposite kidney. So all tubular changes like polyuria, sodium loss, and concentrating ability will be more common in bilateral urinary tract obstruction, and post-obstructive diuresis is particularly is a physiological dialysis seen only in after the relief of bilateral urinary tract obstruction. In unilateral you can see, but it is as already told, common normal kidney can able to compensate it. So it is not much profoundly seen in unilateral. Only in bilateral urinary tract obstruction will be so remember this difference alone. They will ask which mediator unilateral, it is the vasodilator. Which mediator in bilateral urinary tract obstruction, it is the ANP. At what level it will act? It in unilateral, there will be an afferent arteriolar vasodilation. In bilateral, there will be an afferent arteriolar vasoconstriction level. That's all. Simply remember. Just but I due to know better about, I detailedly explain, but it is not much more important. Just remember these triphasic pattern is classical for unilateral urinary tract obstruction. So thank you. So if any questions now you can ask in the group so that we can try to explain. So thank you. Shall we stop the recording?
Okay, so thank you so much for sir for an outstanding session. We got very positive reviews in between the lecture as well. So thank you so much. We hope to see you next time again with another amazing session. Thank you so
Okay,
much.
thank you.
Shall we end the lecture now?